Obstetric hemorrhage. Obstetric hemorrhage divided into antepartum, intrapartum, postpartum. Antepartum hemorrhage defined bleeding after 24 weeks of gestation. The causes of antepartum hemorrhage commonly from the placenta and placental side. The placenta either placenta previa or is normally located placenta, what's called abruptio placenta. The other uncommon causes of antepartum hemorrhage may be uterine rupture, or the bleeding is fetal origin in case of fetal chorionic vessel rupture, and sometimes from the birth canal, cervical or vaginal laceration, or cervical or vaginal lesion including cancer, or sometimes congenital bleeding disorders. And by exclusion of the above, you may say that there is unknown cause. Abnormal placentation. Placenta previa, the incidence of placenta previa, the most common type of abnormal placentation, is of 0.5%, and approximately 20% of all cases of antepartum hemorrhage are due to placenta previa. The predisposing factors for placenta previa may be due to multiparity, decreased maternal age, history of previous placenta previa, multiple gestation, and cesarean section. Classification of placenta previa. Complete placenta previa, when the placenta completely covering the inner os, and maybe partial placenta previa, partially covering the os, the inner os, and a marginal placenta previa, just reaching the border of inner os, and low-lying placenta. Usually the placenta previa presenting as a painless vaginal bleeding in a previously normal pregnancy, and the diagnosis is usually by ultrasonography and a trans-abdominal ultrasound give accuracy around 95%, and transvaginal ultrasound give accuracy around 100%. A premature separation of the normally implanted placenta is called abruptio placenta, and it complicates from 0.5 to 1.5% of all pregnancy. Usually the patient presented with painful vaginal bleeding associated with uterine tenderness and hyperactivity and increased tone of the uterine muscles. Risk factors: maternal hypertension, either chronic or pregnancy-induced hypertension, previous history of abruptio placentae, pregnancy after in vitro fertilization, abdominal trauma, a patient with polyhydramnias, and sudden decompression of the uterine size after ARM, artificial rupture of membrane, premature rupture of membrane, short umbilical cord, folic acid deficiency, and smoking or substance abuse, cocaine, amphetamines. Uterine rupture, the overall incidence is 0.5%. See, the most important cause of uterine rupture is uterine scar and is associated with 40% of cases. The scar either due to previous history of lower segment cesarean section, previous history of upper segment or vertical, what's called vertical or classical cesarean section, history of myomectomy with open cavity that leading to uterine scar, history of perforation, and usually the presentation is a sudden onset of intense abdominal pain, and you can feel the fetal pulse easily by abdominal examination. And we divide the uterine rupture into complete rupture and incomplete rupture. Complete rupture means damage of the uterine wall and involvement of the visceral peritoneum, and incomplete rupture, well, damage of the uterine wall, still the peritoneum intact. In most cases, the treatment is usually end by total abdominal hysterectomy, rarely maybe treated by resuturing of the damaged uterus. Well, management of antepartum hemorrhage. Number one, the patient needs admission for assessment and to exclude severe antepartum hemorrhage. And this depends on general examination and vital signs. During assessment, you have to assess the gestational age and the fetal viability. When you say severe antepartum hemorrhage, mean the condition severe enough that it may threaten the life of the mother. So the treatment is termination regardless of gestational age. And during assessment, if you discover that the fetus is mature, so there is no place to wait, then termination. Antepartum hemorrhage with fetal heart negative also end by termination, and a patient with gross fetal anomalies also end by termination. If the condition is not severe and the maturity of the fetus still not reaching 37 weeks of gestation, and fetal heart positive, and there is no gross anomalies, then the management is conservative. During conservative management, if the maturation of the fetus reaching reasonable level, then termination. If during conservative management the bleeding becomes excessive, then shifted to severe bleeding, then you have to terminate. Okay. If during assessment again, and you discover that there is congenital anomalies, then you have to terminate. When you have a patient with severe antepartum hemorrhage, your aim is to stop the bleeding, and the way is by intrauterus, delivery of the fetus, and then contracted uterus and retracted uterus. Abnormal attachment of placenta either in form of accreta or increta or pericreta, and this may lead to intrapartum hemorrhage during pregnancy and may end with hysterectomy. Postpartum hemorrhage. Postpartum hemorrhage, the leading cause of maternal mortality, is defined as a blood loss in excess of 500 ml at the time of vaginal delivery of the fetus only, not the placenta, or blood loss in excess of 1000 ml following cesarean section. It is divided into primary or secondary. Primary postpartum hemorrhage, blood loss of 500 or more within 24 hours after delivery, and secondary postpartum hemorrhage, significant blood loss between 24 hours and 6 weeks after birth. Causes of postpartum hemorrhage: uterine atonia, retained pieces of placenta, genital tract trauma, laceration of the vagina, cervix, of the lower segment, low placental implantation. Here there is poor retraction, contraction and traction of the lower segment. Uterine inversion, acute uterine inversion may predispose to postpartum hemorrhage, coagulation disorder, amniotic fluid embolism, retained dead fetus and inherited coagulopathy and abruptio placentae. The most important factor that causing postpartum hemorrhage is atonia of uterus, and factors predisposing to postpartum uterine atony are history of postpartum hemorrhage, patient with a prolonged labor, patient with overdistended uterus due to multiple gestation, polyhydramnias, fetal macrosomia, glad multiparity, patient on oxytocic augmentation of labor or induction of labor, rapid labor, what's called precipitated labor, with patient was put on magnesium sulfate treatment, history of infection like chorioamnionitis, utilization of fluthane in anesthesia, presence of fibroid during pregnancy, and vitamin D deficiency and other genetic and epigenetic factors. Prevention: be aware of risk factors may present antenatally or intrapartum. Always treat anemia antenatally because anemic patient cannot withstand normal blood loss after delivery, and anemic patient have low level of myoglobin that may interfere with contraction and retraction of the uterus. Again, it's very important to do active management of third stage and normal vaginal delivery and utilization of oxytocic drugs during active management of third stage and during cesarean section. Here you can summarize the causes of postpartum hemorrhage into tone, tissue, thrombin, trauma. So, previous postpartum hemorrhage, prolonged labor, age more than 40, big baby, macrosomia, multiple pregnancy, placenta previa, obesity can interfere with the tone of the uterine muscle, and other is the retained placenta and membrane and clot may also interfere with contractility of the postpartum, may caused by disseminated intravascular coagulation and may be caused by abruptio placentae, preeclampsia, praexia, intrauterine death, and amniotic fluid embolism. Postpartum hemorrhage can be caused by uterine rupture, laceration of the genital tract, operative delivery like by vacuum or forceps, and cesarean section. Blood loss is commonly underestimated, and the patient may be well tolerated but sometimes not, especially if the patient is anemic. Take care about trickle and moderate low share because this is maybe a first sign of severe postpartum hemorrhage, i.e. minor postpartum hemorrhage can easily progress to major postpartum. When you have a patient with postpartum hemorrhage, then you have to ask yourself whether the placenta is delivered or not. If it is not, then evacuate the uterus by controlled contraction. If it is delivered, then be sure that it is complete. If the placenta delivered, then you have to check the uterus if it is contracted or not. If it is contracted, there is possibility of genital tract trauma. If it is not contracted, then you have to evacuate the bladder and to use oxytocic drug. Then you have to put oxygen, IV fluid, urinary catheter, send for investigation, blood group, RH, and electrolyte and hemoglobin and clotting factors, and transfuse as soon as possible and consider O negative if any delay. You may use oxytocic drug, that's oxytocin, direct or infusion, or ergometrine, or carboprost. Sometime you may use misoprostol sublingually. Other methods in the treatment of postpartum hemorrhage, you may need to do massaging of the uterus. Sometime we may need to do by manual compression or using balloon, tamponade, or sometime by surgery, laparotomy, and B-lunge suture, or using uterine artery ligation and even internal iliac artery ligation. Hysterectomy is the last choice, but before it's too late. That's to say, we have to do hysterectomy before the patient reaching to the level of irreversible shock. This is the picture of bimanual compression, picture of B-lunge suture after laparotomy, and this is picture of uterine tamponade. When you have DIC, then you have to transfuse without delay and consult hematologist, and you need to correct the coagulopathy. Secondary postpartum hemorrhage. The most important cause of secondary postpartum hemorrhage is infection, and the infection either due to endometritis or infected uterine products, or sometimes complication of trophoblastic disease. The aim of treatment is to treat the infection, evacuation of the products if it is present, and correct the anemia by blood transfusion.